Hi everyone. I'm Dr. Avi Singh, currently a neurology resident and someone who's very passionate for medical education. I'm currently applying for my vascular neurology fellowship as well. Today I present to you my passion project, a glimpse into neuromedicine. And today I'll be focusing specifically on how to gamify stroke education, a resident and faculty-led interactive model for early neurology engagement of medical students. Before I go ahead, I wanted to introduce the concept and the purpose of this project. Over the last few years, I have realized that majority of neurophobia or this conscious distance from neurology is at the level of a medical student. And as the years progress, that distance from neurology only widens. And that distance to me has been perceived in terms of people saying either they do not feel comfortable with neurology, or they do not feel they're smart enough for neurology, or they feel they have not been taught in the right way. As a result, I targeted medical students, including MS1s to MS4s, as well as people who are non-neurologists, for example, emergency medicine physicians, as well as internal medicine physicians, to whom neurology seems to be extremely relevant. So, medical students often experience neurophobia, which is a fear of neurology driven by limited exposure and perceived complexity. Despite rapid advances in stroke management, medical education on stroke recognition and acute care remains underemphasized and lecture heavy. Interactive and gamifying teaching methods can improve learner engagement, knowledge retention, and confidence, especially when introduced early in training. So, in our specific intervention, we ended up doing very particular sessions on different aspects of neurology under this umbrella called Shades of Neurology. One of those sessions was specifically targeted towards vascular neurology, which is what we'll be talking today. But of course, all of this can be replicated in different subspecialties of neurology as well. In this session, what we specifically ended up doing was doing a brief didactic session, but as you'll see across the next few slides, those are very limited information on the slide so that the information does not become overwhelming. But we'll focus on everyone, including the students, trying to give answers to the few questions that I ask preemptively based on the limited knowledge that we think they already have, just to establish that there is no fear or we have an understanding of what is the basic knowledge that they know before going into the session, and then we'll be comparing it to what has the change in knowledge been at the end of the session. Importantly, to discuss the methodology of the session, like I said, it's a cross-sectional pre and post-educational intervention. This specific intervention had about 20 medical students across all 4 years, I would say with an emphasis on M1s and M2s. This was a 1 hour session at the max. This was resident led at the time, but of course, you can have attendings as well as other interested people contribute towards the session. There were case vignettes illustrating real world stroke presentations. Gamification was performed via quiz style challenges and live polling. Other components that were included were leaderboards as well as rewards at the end of answering each question. And importantly, the questions, which were specific multiple choice questions that I had designed, were faculty verified, targeting three concepts in this case, which were cortical stroke sign recognition, thrombolysis window knowledge, and CT perfusion interpretation. As you can imagine, it is very easy to dismiss M1s, M2s, and not introduce these concepts. However, the attempt through this intervention was based on common sense and knowledge. How can we make them understand what these concepts stand for? Data collection was through pre and post session multiple choice assessments. Confidence ratings were on a 5 point Likert scale for stroke recognition and management. And there was also a post session qualitative feedback and global helpfulness rating, which was again on a 1 to 5 scale. Importantly, the whole session over the was a part of a bigger project which was being analyzed as part of the Kirkpatrick model, which includes level one as how the reception was, or the reaction of the audience. Level 2 is the knowledge that has been increased or gained over the course of the session. Level 3 is how has there been a behavior change, and level 4 is how the impact has been created at the end of this intervention. This specific intervention as of now and the poster as of now focuses on level 1 and level 2 of the Kirkpatrick model, as you will see. Objective: to assess the impact of a gamified interactive stroke education session on medical students' knowledge and confidence in stroke recognition and management, as well as to explore its potential as a scalable model for longitudinal stroke education. In this specific situation or the intervention, the three specific topics as discussed were cortical sign recognition, thrombolysis window, CT perfusion interpretation, and all of them were seen to have an increase from knowledge pre the intervention to after the intervention, as displayed in front of you. Absolute gain was 17.4%, 29.5%, and 18.7% for the three questions respectively. The important thing to understand there is, although objectively we do have an increase, the people who already got these questions right did endorse a greater understanding of the concept as well, which I think was a very important realization. And I will be talking about how these specific signs were tested in three specific questions before and after. The confidence scores were also perceived to have increased from an average of 2.1 to 3.79 in terms of stroke recognition. The management confidence had increased from 1.35 to 3.74. And importantly, this being a study of its nature, I believe the qualitative feedback was extremely important. The thematic feedback emphasized interactivity, clarity, and engagement, contrasting its favorability with traditional lectures. Just to dive into a little how the questions were pretty much framed were based on cortical sign recognition. Not just what cortical signs are, but what is the value of identifying cortical signs? What is the value of identifying a patient having aphasia, visual field neglect, gaze preference, or these signs being a surrogate for that a large vessel might have been occluded, which translated to the need for a CTA and translating to the potential of mechanical thrombectomy being offered in a patient. This was a concept that was emphasized through a 2-minute micro teaching session and yielded better results in terms of them understanding the value of recognizing cortical signs than just cramming what cortical signs were. Another concept that was tested was the window of acute intervention. A lot of students initially did not realize the difference in the windows for intravenous thrombolysis as well as mechanical thrombectomy. However, once the concept was explained through this gamified intervention, they realized when and when not was intravenous thrombolysis offered, when and when not was mechanical thrombectomy offered, what was the rationale behind the two, and when could both of these be offered as well as both of these were not being offered. The third concept that was being tested, which relatively seems to be advanced for medical students, was CT perfusion interpretation. And in this case, it was kind of explained the need for a CT perfusion imaging in certain situations. The concept of salvageable tissue was explained and how a CT perfusion scan helps detect that and how that makes a difference in a person becoming a candidate for mechanical thrombectomy. Of note, the session was limited to 3 teaching points because it was understood that there is only a limited time and we did not want to overwhelm the students, but rather get an understanding that if taught correctly, these were concepts that could be well understood by the students and retained for a very, very long time. At the same time, it was important for the students to realize that neurology was well within their grasp and even complicated concepts could be well understood if they were taught the right way and at the right time. Basically, gamified learning enhanced both knowledge and confidence in acute stroke care among medical students. That was a big realization at the end of this intervention. The intervention also demonstrated strong acceptability with students reporting high satisfaction and engagement. Faculty verified content ensured educational rigor while maintaining interactivity. And tailoring content complexity to the learner's stage supported scalability for diverse student levels. To conclude, a brief interactive gamified stroke session significantly improved knowledge and confidence in medical students. Of course, the sample size in this study was extremely small, and we continue to increase our sample size by doing this session across multiple universities and multiple platforms. But the trend seems to be very reassuring. Collaboration with student interest groups can serve as a scalable model for national implementation. As in this case, I had collaborated with the student interest group of neurology at my own institute. The future work would include developing a longitudinal curriculum starting early in medical school, integrating neurophobia assessment and career interest designing. Such programs may foster early engagement with neurology and strengthen stroke education globally. An important takeaway that I want everyone to have from this intervention is by targeting M1s through M4s, the goal is not for everyone to be interested in specifically choosing neurology, but rather making them very comfortable with neurology regardless of whatever subspecialty or specialty within medicine they end up choosing. Since neurology, and especially stroke, acute stroke recognition and recognition of acute signs and symptoms of stroke being very important. I will just go over a few slides to show you a glimpse of what are the brief slides I went over with the students during my session. This is how the session starts. There's a brief session about what strokes are. And as you can see, these are supposed to be very limited. A few signs that must be recognized when you're concerned for a stroke. I did go into a little of the pathophysiology, how were strokes divided, just so that all of my audience was at the same place in terms of understanding before attempting to answer the questions. How the management of stroke differs based on the timing when the stroke was alerted. This was a very brief version of what we do during a stroke alert, which included finding pertinent vitals, determining blood pressure and glucose, doing a brief history, which includes very specific questions, and a brief neurological exam as well as the NIH stroke scale. The pertinent history included last known well, blood thinners, history of prior strokes and seizures, any history of dementia, and functional baseline, and how that impacts the decision for an acute intervention. Identifying patients for who is within the window for both intravenous thrombolysis and mechanical thrombectomy. Of course, these are guidelines that are currently changing as more research comes, but the concept building was the most important part that was targeted. Then interpreting images, the need for a non-con CT to kind of rule out a stroke, as well as the need of a CT angiogram to identify a large vessel occlusion. And ultimately, how does that lead to having a person being offered an acute intervention, be it IV thrombolysis, mechanical thrombectomy, or dual antiplatelet therapy? We did go over briefly over what are other aspects of management and relevant parts that might be important to understand for answering the questions without specifically answering the questions that would be asked. And this is the part that is gamified, the gamification element of the didactic session, which took about less than 30 minutes of the whole session. For example, this was a question which was themed specifically on interventional neurology. And every question with all its choices has been designed specifically to tailor a concept building exercise. Which of the following makes it least likely for a patient to receive mechanical thrombectomy? A. Last known well of about 6 hours. B. Patient already having received IV thrombolysis. C. CTA did not show any large vessel occlusion. D. CTP shows salvageable brain tissue. And this is something that they were supposed to answer before, and a similar question that was supposed to be answered after the whole didactic session. And we went over through the whole process of why and why not was every answer relevant or not. They understood that mechanical thrombectomy's window is separate from IV thrombolysis. So A does not necessarily rule out. B means patient having received IV thrombolysis does not exclude a person from receiving mechanical thrombectomy, kind of reiterates the concept that these are two separate windows and a patient can receive either. And CTP showing salvageable brain tissue means there's tissue to save. However, the answer being if a patient does not have a large vessel occlusion, they should be considered and a mechanical thrombectomy can be performed even if IV thrombolysis has been already given. This was a concept that was built on the commonsensical concept that if you do not see a jam on the highway, there is nothing for you to clear. Hence, understanding a CTA is important to identify a large vessel occlusion, which is, of course, then important to potentially go after the vessel to remove the occlusion. And this was a concept that was very beautifully received by the students, even if they were medical students year one. Similarly, there was a question on facial droop regarding how do you differentiate between a lower motor neuron versus a upper motor neuron lesion of the facial nerve and an motor neuron lesion, of course, being concerning for a stroke. These were all concepts that were relevant to medical students, emergency medicine physicians, as well as internal medicine physicians. I will move on to show you how the explanation slide looks like, but basically limiting the explanation to just a few important caveats and making the concept relevant to how the students and physicians would be seeing in their setting. And how does that concept identification correlate to a neurology consult? This is another concept, which is medical management of strokes. When and when not, in the absence of a PFO, would you consider a thromboembolic cause in an artery for a patient concerning with a stroke related finding? All in all, this question boils down to which of these conditions is most concerning to have arterial thromboembolic events. And that turns out to be antiphospholipid syndrome. And of course, how you can help the students to remember the obviously cramming looking concepts by developing mnemonics that are meaningful and can be remembered for a long time. For example, in this case, waging a war against the antibodies helps you tie in the concept of warfarin is the anticoagulation management for antiphospholipid syndrome. This is another way you can gamify and kind of help your students learn better. And this again is a question which is a certain kind of is a different category of a question where you end up choosing one of the four false statements, but all the four statements have their own learning points at the end of the day. For example, internal capsule is gray matter. B, if you suspect a cortical stroke, the gaze deviation is classically expected towards the lesion. C, adrenal medullary cells are derived from the fourth germ cell layer. And D, hip flexion worsens pain due to sciatica, whereas it relieves pain due to spinal canal stenosis, which is shopping cart signs. As you see, you can kind of have one or at max two of such questions because, as you can see, they're very dense questions. However, they offer a teaching exercise. The concept that is being used here is called interleaving, which is different concepts within neurology being taught at the same time so that the confusion is less. And importantly, these all have to have one very specific teaching point at max that is not too much to absorb. In this case, the teaching point ended up being that the direction of your gaze or the gaze preference in the case of a stroke is towards the infarct. That was the teaching point that we wanted to give away. And the lesson taught was basically if you have a stroke, you're pulling the eyes towards the infarct, and if you have a seizure, you're pushing it away. Of course, you can tie in the learning points of the other choices, but the important thing is to focus on the concept that you're trying to teach during that session, which ended up being strokes and vascular neurology for this topic. At the end, the goal of the session was to build comfort and confidence when it comes to talking and thinking about neurology, which is perceived as a vast ocean. So we know an ocean about neurons and not even a drop when billions of them come together to emerge as brains. It's what we allow to overpower us, fascination or fear, that decides whether the tiny neurologist in each one of us lives or dies. Hopefully, you all enjoyed the session. Thank you so much.